dural folds. Okay, dural folds and dural venous sinuses. Next. See, this is cranial cavity. This is scalp. Okay, this is cranium, cranial bone. This outer belly, inner belly, and lymph tissue. That's it. And this is one venous sinus, superior sagittal sinus. 3 layers of the meninges. This is durameter. P1 is the arachnoid matter, forming arachnoid granulations within the superior sagittal sinus. And this green one is the pars mater. Okay. Underneath the durameter there is the subdural space. Here underneath the arachnoid matter is subarachnoid space. Okay. And outside the durameter will be the extradural space. These are the 3 common spaces where the hemorrhage can occur. See, all these initiating veins are draining into this sagittal sinus. So the cranial cavity is enclosed within the skull and communicates with the exterior through the numerous small and large foramina. And contents of the cranial cavity are brain, meninges. This is brain tissue covered by the green color pars. Meninges 3 layers. You have seen 3 layers. Outer durameter, middle arachnoid matter, and inner pars mater. Then hypophysis cerebri, that is pituitary gland, intracranial parts of the cranial nerves, dural venous sinuses, including the cavernous sinus. Arteries are the internal cavity arteries, 4th point of particular arteries, circle of Willis, and middle meningeal arteries. All these are included in the cranial cavity. Okay, next. So the interior of the cranial cavity is lined by durameter. This is the durameter, and the surface of the brain is covered by 3 pars mater, the green one. Arachnoid matter, and in the middle there is a layer called arachnoid matter that connects the durameter with the pars mater. This is the arachnoid matter, violet one. And the potential space between the durameter and arachnoid matter is subdural space. Here, this white colored layer is the subdural space. Subarachnoid space, it is space between the arachnoid matter and pars mater, and it is filled with CSF. This below this arachnoid matter here, this area is the subarachnoid space, and it is filled with CSF. Next we will discuss the durameter in details. Okay. So the sagittal or cranial durameter is thickest, toughest, and outermost fibrous membrane covering the brain. Dura means heart, matter means mother. So comes from a Latin word. It is a heart covering, fibrous covering. And what are there are 2 layers of the durameter. Outer endosteal layer, which is attached to the bone, and inner meningeal layer. And these layers are fused with each other except at the site of cranial venous sinuses. Endosteal layer or endocranium, it is the outer layer of durameter. It lines the inner surfaces of the skull bones in the form of periostea, and it's called the endocranium. Features continuity. The endosteal layer is continuous with the pericranium on the outer surface of the skull through the sutures and foramina of the skull, and it is also continuous with the periosteal lining of the orbit through the superior orbital fissure. So this is the continuity of the endosteal layer. And dural sheath. Endosteal layer provides dural sheaths for cranial nerves, which fuses with the peritoneum. And passage for meningeal vessels, endosteal layer is passage to the meningeal vessels, and adherence, it is loosely attached to the inner surface of the vault of the skull and makes it easily separable, and it is clearly attached to the base of the skull and margin of foramen magnum. Okay. Next, see these are the different folds of the dura mater. You can see here this fold, single sepal fold. This is falx cerebri. Okay. Here the same line fold is the anterior cerebellum. Here in the lower part, here the occipital region, right is falx cerebri. Here lies the falx cerebellum. Falx cerebri was separating two cerebral hemispheres, right and left hemispheres of the brain. And falx cerebelli we separate two cerebellar hemispheres. Okay, right and left hemisphere of the cerebellum. Okay, so we will discuss these processes, dural folds and velar sinuses. Next. So the dural seat of the optic nerve fuses with the sclera of the eyeball, and another layer is meningeal layer. It is inner layer of the dura mater, and it encloses the brain and continues downward through the foramen magnum with the dura mater of the spinal cord, spinal dura. Spinal dura has only one layer, this meningeal layer only. Okay? Only cranial dura mater has two layers, endosteal layer and meningeal layer, because it has to enclose the venous sinuses in between these two layers. Okay, that's why two layers are present in the cranial cavity. Okay, now we have to see the folds of the dura mater. Meningeal dura mater is folded on itself at some places to form the partitions which divide the cranial cavity into different compartments. So these are the folds: falx cerebri, anterior cerebelli, falx cerebelli, and diaphragmal cerebri. Diaphragmal cerebri is lying over the hypophyseal fossa, okay, over the body of the swimmer. Next, see this is a coronal section through different areas. This is in the posterior cranial fossa, this is in the middle part, and this is anterior. Okay, so you can see here, this is venous sinuses. At the superior, in the mid line, there is superior sagittal sinus. This is falx cerebri. At the lower margin of the falx cerebri, there is inferior sagittal sinus. And on the two sides, these are the transverse sinuses. Okay, and these folds are the anterior cerebelli, separating brain from the cerebellum from the cerebellum. Okay, and this is in the middle part. Here you can see the falx cerebellar. These are and here is the anterior cerebellar. This is straight sinus. There is the superior sagittal sinus. Okay, here also you can see the same things. See here, along this lower margin of the falx cerebri, here is the inferior sagittal sinus. And along the cranial cavity in the midline, we have superior sagittal sinus. These two are connected by straight sinus here. Okay, and along the margin of the anterior cerebellum, here lies the transverse sinuses, and here along the margin of the petrostemporal lies the petrosal sinuses. On the two sides of the body of the sphenoid lies the cavernous sinuses. Okay, all those sinuses are important. Next, falx cerebri is a large single-celled fold of dura mater that occupies the median longitudinal fissure between the two cerebral hemispheres. It has two ends, two margins, and two surfaces. Anterior end is narrow, attached to the crystal gallery. Crystal gallery of the influenza, the seen in anterior cranial fossa. Posterior end is broad and it is attached to the upper surface of the anterior cerebellum in the median plate. Here seen in previous picture. Upper margin is convex, attached to the leaves of sagittal sulcus. Lower margin is concave and free. And right and left surfaces of the falx cerebri are related to the medial surface of corresponding cerebral hemispheres. Related dural venous sinuses, three important dural venous sinuses are present in relation to falx cerebri. Superior sagittal sinus along the upper margin, Inferior sagittal sinus along the lower margin and straight sinus along the line of attachment of cerebral with the anterior cerebellum. Okay. Next. So this is definition. Large single segment fold of neural matter lies in the medial longitudinal fissure of brain. These are anterior end attached to crystalline, posterior end attached to anterior cerebellum, upper margin attached to sagittal sulcus, lower margin is concave and free. And these are the related sinuses: superior sagittal sinus, inferior sagittal sinus, and straight sinus. Okay, we have discussed previously. Next we go to tentorium cerebellum. Okay, tentorium cerebellum, it is a 8 separate fold or dura matter that forms the roof of the posterior cranial fossa, and it separates the cerebellum from the occipital lobe of the cerebrum. These are the parts. It has two margins and two surfaces. Anterior or inner margin, it is a free margin. This attachment is asked, okay, where lies the free margin, where is the attached margin is attached. This is asked during your base of the skull, okay, in your fiber, bones fiber. So anterior or inner margin, it is a free margin. It is a U-shaped and it closes with tentorial notch and incisura for the passage of the midbrain. And anterior ends of this U-shaped margin are attached to the anterior thyroid process. Okay, that was posterior projection of the lesser lymph of medulla. Posterior or outer margin, it is an attached convex fixed margin, and its attachment extends from the posterior thyroid process, superior border of the temporal bone, petrous temporal, posterior inferior angle of the parietal bone, and leads of the transverse sulcus on the occipital bone. So this is the attachment of posterior margin, outer margin, or attached margin of the temporal cerebellum. Then upper surface is convex and slopes in either side of the median plane, gives attachment to the paracerebral in the midline. At the due to attachment to paracerebral, middle part is convex. Lower surface is concave, gives attachment to side cerebellum in the midline, only in the posterior part. Okay. Now, venous sinuses related to the tentorium cerebelli are the transverse sinus along the posterior part of the attached margin, superior petrosal sinus along the anterolateral part of the attached margin, and straight sinus along the line of attachment of paracerebral. Okay. So these are the venous sinuses. Next, see here. This is tentorium cerebelli. Okay. This U-shaped margin is the free margin. Okay. This is free and hanging freely, and its anterior end is attached to this anterior thyroid process. Okay. And attached margin, this part is the attached margin, is attached to the posterior thyroid process. Then petrous part of temporal bone, then along the transverse sulcus of the posterior cranial fossa, okay, up to this midline, where is the confluence of sinuses. And see the venous sinuses. Here there is the straight sinus in the midline plane. Here are the transverse sinuses. Okay, and along this margin, along the petrous temporal, lies the superior petrosal sinus. Understood? Okay, and all these sinuses are joining here at this point, that is known as confluence of sinuses. Okay, so this tentorium cerebellum is discussed. Next, neural fold is diaphragma cerebellum. See, this quadrangular separate fold is known as diaphragma cerebellum. Okay, it is breaching between the anterior thyroid process and the posterior thyroid process. And this opening is for the aperture for stalk of the pituitary gland. Here there is a hypophyseal fossa for lodging the pituitary gland, and through this opening in the diameter, the stalk is passing, stalk of the pituitary gland. Understood? And these are the third and fourth round. This we are seeing the diameter here. Okay, understood? Next. So tentorium cerebellum, 8 separate fold of diameter forms for posterior cranial fossa. separate cerebellum from occipital lobe. These are the parts pre-margin, inseparate encloses tentorial margin. Attached margin is convex and fixed, extends along the posterior cranial process, superior border of temporal bone and transverse sulcus. Upper surface gives attachment to phalanx cerebri, lower surface gives attachment to phalanx cerebellum. Related sinuses of these three: transverse sinus, superior petrosal sinus, straight sinus. You have seen in the previous picture. Next. Okay. Now, trigeminal or wicked space, it is a recess of dura mater present in relation to the attached margin of the tentorium. Here, the trigeminal ganglion is lying here. That's why this is known as wicked scale or trigeminal scale. It is formed by evagination of the meningeal layer of dura mater over the trigeminal impression of the petrous temporal, and trigeminal cave lies below the superior petrosal sinus. Next we go to phalanx cerebellum. Okay, phalanx cerebellum is a small sickle-shaped fold of dura mater projecting forward into the posterior cerebellum notch. It has a base affixed to margin. Base is attached to the posterior parts of inferior surface of tentorium cerebellum in the median plane. Apex is usually divided into two parts which merge with margins of foramen magnum. Posterior border is convex and is attached to the internal occipital crest, that is external from internal occipital protuberance to the margin of foramen magnum. And anterior margin is free and convex. Venous sinus related to phalanx cerebellum is occipital sinus lies along the posterior attached margin of the phalanx cerebellum. Okay. Next is diaphragm cell. This is last four we have discussed. We have to discuss phalanx cerebri, phalanx cerebelli, tentorium cerebelli, and diaphragm cell. Okay, it comes as a short code, dural folds. Okay, dural folds can come as a short code. We have to discuss shortly all these four folds. Okay. So the diaphragm cell is a small circular horizontal fold of dura mater, and it forms the roof of the hypophyseal fossa. Attachments anteriorly to the tuberculum cell, posteriorly to the dorsum cell. On each side continuous with the dura mater of the midcranial fossa. And central aperture of diaphragm cell provides for passage to the stalk of the pituitary gland. Okay, you have seen in the picture. Now, blood supply of the dura mater. Blood supply of endosteal layer of dura mater, it is rich in vascular, provides nourishment to adjacent bone, and it is supplied by meningeal branches of ophthalmic, anterior and posterior inguinal arteries in the anterior cranial fossa. And medial and accessory meningeal arteries and meningeal branches of internal carotid and ascending pharyngeal arteries in the midcranial fossa. And meningeal branches of vertebral and occipital arteries in the posterior cranial fossa. So these are the blood supply of the dura mater. Okay. Next one. आगे क्या है? So interesting. The meningeal layer of dura mater is more fibrous and less vascular, and the meningeal arteries are the chief source of blood supply to the bones of the skull. Scapula is a two-thickness soft tissue, is a removal of the fat. This process is known as scapula, and it does not result in the necrosis of the underlying bones, as these bones receive very little blood from the vessels of the skull. Okay. Next is nerve supply. Innervation of dura mater is very important for understanding the headache and other clinical conditions. Okay. So these nerves are supplying dura mater. Ophthalmic nerve supplies the infratemporal dura mater. Okay. below the thyroid. And anterior and posterior inferior nerves and maxillary nerves supply the dura of the anterior cranial fossa. And maxillary and mandibular nerves supply the dura mater of middle cranial fossa. And recurrent branches of first, second, and third cranial spinal nerves and meningeal branches of ninth and tenth cranial nerves supply the dura. So in the different cranial fossa, we have different supply of the dura mater. Okay, different nerve supply. Next. Okay. Pain sensitive intracranial structures are the dura mater, large cranial venous sinuses, and then is dural arteries and intracranial arteries. And cause of headache can be infection or inflammation of the dura mater, inflammation of extracranial structures supplied by nerves supplying the dura mater, that is for referred pain, dilation of intracranial arteries, raised intracranial pressure by CSF, quantity or space occupying lesion. Okay? The cranial cavity is a fixed cavity. Okay? If any of the structure increase in volume, another structure have to reduce in size. Okay? So these are the four pain sensitive structures. So if any of these are involved, there will be pain and headache. Next, two types of hemorrhages are important: extradural hemorrhage and subdural hemorrhage. Extradural hemorrhage occurs between the skull and endosteal layer of dura mater. Subdural hemorrhage between the dura mater and arachnoid mater. Involved vessels for extradural hemorrhage is arteries in the meningeal artery, and for subdural hemorrhage, many veins are involved. Symptoms are there is rapid onset of symptoms, that is sudden onset of paralysis in extradural hemorrhage, okay, in stroke, and since subdural hemorrhage gradually increasing symptoms. Okay. Now blood in the CSF, it is absent in extradural hemorrhage because it is lying outside the dura mater. Here it is present, subdural hemorrhage, because it is very near to the arachnoid mater and it may enter also into the subarachnoid space. Subarachnoid space CSF is lying. Now CT scan appearance of hematoma, it appears as biconvex lace type. Okay? Biconvex. That you have to remember even reading the CT plate. Okay? And subdural hemorrhage, it is presensitive. Okay? This is subdural hemorrhage and this is epidural. Okay, outside the dura mater, this is endosteal layer and this blue one is the meningeal layer of dura. So this subdural hemorrhage is lying through this dura and epidural is outside the dura. Okay. Next. Okay, so now we will discuss the intracranial dural venous sinuses. The dural venous sinuses are the venous spaces and channels present in the dura mater lined by endothelium. Okay, endothelium is outline of the blood vessels. These are also veins, that's why outline of blood vessels will be present endothelium. Dural venous sinuses are formed by two ways: by separation of two layers of dura mater and by folding of meningeal layer on each side. Features of dural venous sinuses, they lie between the layers of the dura mater, between endosteal and meningeal layer, and lined by endothelium only. Muscle is absent in their walls, devoid of valves in their lumen, receive blood and CSF both. Okay? Communicates with veins outside the skull through the emissary veins and helps to maintain the constant blood pressure in the cranial cavity. Okay. Next. So these are the list of the dural venous sinuses. Okay. This also known as a short note. Dural venous sinuses or important cavernous sinus individually can come as a short note. Cavernous sinus very to prepare or everything about cavernous sinus. Okay. So there are about 21 dual venous sinuses grouped as paired sinus and unpaired sinuses. Paired sinuses are cavernous sinus, superior pectoral, inferior pectoral, transverse, sigmoid, sphenoparietal, and pectoral. These are the paired sinuses. Unpaired sinuses, they lie in the midline. Superior sagittal, inferior sagittal, straight sinus, occipital sinus, anterior intercavernous, posterior intercavernous, and vestibular plexus of face. Okay, we will discuss now the important sinuses in details. So these are the paired and unpaired venous sinuses. Next, see the sinuses. Okay, these are the two cavernous sinuses on the two sides of the body of the sphenoid. Okay, in the meantime, along the sagittal suture, here there is the superior sagittal sinus. Okay, complex margin of fat cerebri. Along the lower margin of fat cerebri lies the inferior sagittal sinus, and it is joining with the great cerebral vein or vein of gland. Okay, and forming this straight sinus. Straight sinus is draining in the confluences of sinuses. Okay, here the two transverse sinuses are joining. This is one transverse sinus, there is one transverse sinus. And these are the two superior pectoral sinus. They are joining this transverse sinus. Okay? And transverse sinus are continuing downward as the sigmoid sinus. Sigmoid sinus is coming out through the foramen maceram as the internal jugular vein. Okay? And this cavernous sinus is connected to the internal jugular vein by this inferior pectoral sinus. And here are the sphenoparietal sinus and the junction of sphenoid, lesser margin of the along the margin of the lesser wing of the sphenoid. And these two cavernous sinuses are connected by anterior and posterior intercavernous sinuses. And here is the occipital sinus along the margin of the attachment of pharynx cerebellar. Here is occipital sinus. Next. So these are the paired and unpaired sinuses. You read the names. Next. So lateral sinus, main sigmoid sinus and mastoid sinus, they are together known as lateral sinus. And medial meningeal vein is called medial meningeal sinus. Okay. Next. Next we go to cavernous sinus. Very important topic. Cavernous sinus. Okay. Cavernous sinus is a large dual venous sinus that lies between the two layers of jugular. Size is made 2 cm, width is 1 cm. Where is the location? Each cavernous sinus lies in the meningeal fossa on either side of body of the sphenoid bone. What are the parts? The cavernous sinus lies between the two layers of jugular. Each cavernous sinus has a roof, one probe and two valves, medial valve and lateral valve. Roof and lateral valve is formed by the meningeal layer of jugular and probe and medial valve is formed by the endoscopic layer of the jugular. Next. Okay, interior of the cavernous sinus is divided into a number of small spaces or caverns by trapectory. Okay. Trapectory means projection. Hence called cavernous sinus. Okay, that's why the name is given. And the trapecula are less conspicuous in the living than in the dead. Okay, more prominent in dead. Next, see this is section, coronal section to the cavernous sinus. These relations are also asked. If it comes as a long question, relations are also asked. So each sinus extends anteriorly up to the medial end of superior orbital fissure and posteriorly up to the apex of petrous part of temporal. These are the relations, superior relation, optic galma, optic tract, olfactory tract, internal capillary, anterior perforating substance. Here you can see this is the optic galma, here are the internal capillary arteries and other things we see in the perimeter. Okay. Inferiorly, here lies the foramen lascera and junction of the body and retractile of the sphenoid bone. Okay. Medially, pituitary gland, sphenoidal layer sinus. See here, this is pituitary gland and this is sphenoidal layer sinus within the body of the sphenoid. So these are lying medial to the sinus. The blue colored one is the cavernous sinus. Okay. Laterally, medially pituitary gland and sphenoidal layer sinus. Laterally, temporal lobe with the uncus. Okay, temporal lobe of great uncus is projecting from the temporal lobe. Anteriorly, there is superior orbital vessel. Posteriorly, apex of petrous part of temporal lobe. So these are the relations. Next, see this is a schematic diagram of cavernous sinus. See this is that type of ceiling. This is the aperture. Here is the hypophyseal muscle along the pituitary gland, pituitary stalk. This is within the body of the sphenoid. These are the sphenoidal layer sinus. And these are sections in the cavernous sinus. You can see the internal carotid artery is passing through the cavernous sinus. And along with it like this, 6 nerve at abduction nerve. Okay. Then on the lateral wall of the cavernous sinus lies the third and fourth nerve. Okay. Third, fourth, and sixth. These are going anteriorly to enter into the orbit through the superior orbital vessel. Okay, so ocular, trochlea, and abducens will enter into the orbit. And also the 3 divisions of transcendental nerve also lying in relation with the cavernous sinus. This is ophthalmic nerve, here is the maxillary nerve, and here is the mandibular nerve. Okay. Next. So cavernous sinus, it is a dural sinus lies in between 2 layers of duramata. Size is 2 cm and 1 cm. Location in the meridian to the minor side of body of sphenoid. Parts, roof and lateral wall formed by meningeal layer of duramata. Floor and medial wall formed by endoscopic layer of duramata. Extend anteriorly up to the superior orbital vessel, posteriorly up to the apex of petrous temporal. Relation you have seen in the previous picture. Okay. Next. Now this is important. Structure in the wall of the cavernous sinus. Structure within the lateral wall from above downward. In the previous picture you have seen oculomotor nerve, trochlea nerve, that is third and fourth nerve, ophthalmic division of trigeminal nerve. According to recent concept, maxillary nerve does not run from the lateral wall of cavernous sinus, and this nerve traverses beneath the duramata of the meridian fossa below the level of cavernous sinus. And structure passing through the cavernous sinus are the internal carotid artery and sympathetic plexus around it, and abducent nerve. All this you have seen in the previous picture. So these relations are important. In the lateral wall lies the oculomotor, trochlea, ophthalmic nerve, and within the sinus lies the internal carotid artery with sympathetic plexus and the abducent nerve. Next. Okay, these are the structures you have to dissect out according to. Okay, oculomotor nerve, trochlea nerve, ophthalmic nerve, maxillary nerve. Doleros canal. The abducent nerve enters the cavernous sinus by passing through a dural tunnel known as Doleros canal. And internal trochlea or Parkinson's triangle space between the trochlea nerve and ophthalmic nerve in the lateral wall of cavernous sinus. And okay, so this structure you have to dissect. You dissect that again. Next. Okay, so what are the tributaries of cavernous sinus? This you have to write. Okay, giving you short note. So cavernous sinus, this is blood supply from the orbit via the superior ophthalmic vein, inferior ophthalmic vein, central vein of retina. This is present somewhere. From the brain via the superficial mid-cerebral vein, inferior cerebral vein from the temporal lobe, and from the main place via the sphenoparietal sinus and frontal or anterior trunk of medial meninges. Okay. Next. See sphenoparietal sinus, and this is anterior intercavernous sinus connecting the two abdominal sinus, posterior intercavernous sinus. Okay, and see, these are the vesical venous plexus, superior petrosal sinus, inferior petrosal sinus, frontal trunk of medial veins, sphenoparietal sinus, superior inferior optic vein coming from the orbit, okay, and also inside veins are getting into this diaphragm sinus, inferior cerebral veins. Next, okay, next. So central vein of retina may drain into the superior ophthalmic vein or into the cavernous sinus. There are many variations. Anterior trunks of medial vein may drain into the sphenoidal or cavernous sinus, or it may pass through the foramen oval and drain into the thyroid venous plexus. Next, communication. Communications are important for different clinical aspects related to cavernous sinus. So, cavernous sinus communicates or drains into the following veins or venous sinuses or plexuses. Via the lymphous sinus, it is connected to the transverse sinus via the superior petrosal sinus. This is the superior petrosal sinus connects the cavernous sinus to the transverse sinus. Internal jugular vein via the inferior petrosal sinus. Inferior petrosal sinus connecting it to the internal jugular vein. Carotid venous plexus via emissary vein passing through foramen oval lacerum and emissary sphenoidal foramen. See here, this is thyroid venous plexus, it is connected by the veins. Then to the facial vein through two ways. It is connected to facial vein via superior ophthalmic vein and then via the angular vein. Here, superior angular vein, angular vein is connected. Okay? And emissary veins to the thyroid venous plexus and then deep facial vein. See, emissary vein to the thyroid venous plexus and then through the deep facial vein, it is connected. Deep facial vein coming from the vein to enter into thyroid venous plexus, then via the emissary vein into the cavernous sinus. Next, superior sagittal sinus. See here, superior sagittal sinus. Okay, this region is mine. Connected by the superficial midcerebral and superior anastomotic vein. And internal vertebral venous plexus via the basilar venous plexus and opposite cavernous sinus via the anterior and posterior intercavernous sinuses. So all these communication are valve-based. So blood can flow in either direction, into the cavernous sinus, out of the cavernous sinus. Okay? And in case of embolism in these sinuses, there will be emboli will pass into the cavernous sinus and can lead to infection in the cavernous sinus. Okay? And there will be meningitis. And the following factors regulate or help in expansion of blood flow to the cavernous sinus. Pulsation of the internal carotid artery and the cavity pressure. Next. So structures in the wall of cavernous sinus, lateral wall, ocular, trochlear, ophthalmic nerve, through the sinus, internal carotid artery, adjacent nerve. These are the typically superior, inferior, ophthalmic vein, central vein of retina, superficial, medial cerebral vein, inferior cerebral veins, sphenoparietal sinus, frontal trunk of medial vein. And these are the connections to the transverse sinus via superior petrosal sinus, to the internal jugular vein via inferior petrosal sinus, thyroid venous plexus via emissary vein, facial vein via superior ophthalmic vein, emissary vein, and to the superior sagittal sinus via superficial medial cerebral vein and superior anastomotic vein. Internal vertebral venous plexus via basilar venous plexus, opposite cavernous sinus via anterior posterior intercavernous And these are the two clinical aspects: cavernous sinus thrombosis and carotid cavernous sinus fistula. There is the arterial venous fistula if the communication occurs between the internal carotid artery and the cavernous sinus. Next, each cavernous sinus differs from an incorporation of small plexiform tubules during the development makes the interior of cavernous sinus trabecular. Next, so cavernous sinus thrombosis is important clinical aspect. It is a common due to numerous communication may be caused by infection of dangerous area of face, nasal cavities, paranasal sinuses. What are the signs and symptoms? May cause involvement of ophthalmic pain, severe pain in the eye and forehead, involvement of third, fourth and fifth cranial nerves, ophthalmoplegia, paralysis of ocular nerves, congestion of orbital veins, edema of iris and exophthalmos. Then next, so these are the signs and symptoms of the cavernous sinus thrombosis. Next clinical aspect is carotic cavernous sinus fistula. Direct communication between internal artery and cavernous sinus may occur due to direct drainage tube or rupture of aneurysm. Results in parasitic exophthalmos, protruding and considered eyeball, ptosis, periorbital edema, alternate involvement of third, fourth and sixth cranial nerve, diplopia and so on. Tumors may arise within the cavernous sinus such as meningiomas, hemangiomas and may stay into the cavernous sinus from the adjacent region such as pituitary adenomas. These may also involve the cavernous sinus. Pituitary gland is lying in medial relation with the cavernous sinus. Next we will discuss the other important sinuses. Okay. So cavernous sinus you prepare as a short note, very important. Distributaries, relations, okay, and different clinical aspects are important. So superior sagittal sinus lies between the two layers of fat cerebri along its upper convex and attached margin. Begins anteriorly at the crista by union of tiny meningeal veins, termination at the internal occipital protuberance. Usually continues at the right cavernous sinus which later becomes sigmoid sinus. It is triangular in cross section, arachnoid granulosus project into the lumen of the sinus and numerous fibrous bands cross the lumen at the inferior angle of the sinus. These are the tributaries: superior cerebral veins, parietal and axillary veins, 8 to 12 in number. Small vein from the nasal cavity, veins of frontal layer sinus. These are the clinical aspect thrombosis of superior sagittal sinus. It may occur due to infection of dangerous area of face, scalp, and diploid. Okay, it has connection with these areas. Inferior sagittal sinus, small channel lies in between the lower layers of lower pre-concave margin of pharynx. It ends by joining the great cerebral vein of gland to form the straight sinus. Okay. Next we go to straight sinus. Location lies in the medial plane along the junction of pharynx cerebri and tentorium cerebri. It is formed by fission of the inferior sagittal sinus with the great cerebral vein. Termination at the internal occipital protuberance and the straight sinus continues as the transverse sinus, usually on the left side, and it receives few superior cerebral veins. Next we go to the transverse sinus. Okay, so superior sagittal sinus, it was continuing as the right transverse sinus, and the straight sinus was continuing as the left transverse sinus, and both the transverse sinus are continuing as sigmoid sinus. So see here, transverse sinus location is situated along the posterior attached margin of the tentorium cerebri. It launches in a groove extending from internal occipital protuberance to the maxillary angle of the temporal parietal. formation usually in the right side, superior sagittal sinus continues as transverse sinus, and on the left side, the inferior sagittal sinus continues as the transverse sinus. Confluence of sinuses, what is this? This is very frequently asked in your file. What is confluence of sinuses? Okay, urinary bones. Confluence of sinuses is also known as stortular bilophilia. It is a connecting point of three sinuses, superior sagittal sinus, straight sinus, and occipital sinus, and it lies at the internal occipital protuberance. It is named after bilophilia, which is a Greek analogs. Next. Okay, next is sigmoid sinus. The transverse sinus is continuous downward as the sigmoid sinus. You see in this picture, occipital sinus situated along the attached margin of cerebellum. Okay, next. Okay, you see in this picture. Next. Okay, vesical venous plexus is plexus of veins lies in front of pons and medulla on the tripus, that is sloping part of vesicle. It connects the two inferior petrosal sinuses and internal vertebral venous plexus. Okay. Next. See, this is the vesicular venous plexus. Next. Sphenoparietal sinuses. Okay, these are lying along the margin of the basal margin of the sphenoid. Okay, so lesser way of the sphenoid and great into the anterior part of the cavernous sinus. Next, these are along the petrous part of temporal, upper margin superior petrosal sinus, lower margin inferior petrosal sinus, petrosperma sinus. Okay. Next, anterior posterior intercavernous, connecting the two cavernous sinus, circular sinus, intercavernous sinus, and cavernous sinus together forming the circular sinus, and very peculiar veins are also known as lymph. Next. Okay, that's your scene. Next. Okay, these are connecting veins. Superior anastomotic vein of shoulder and superficial cerebral vein. And this is inferior anastomotic vein of labrum. Next. Okay, these are cavernous sinus. Next. Okay, so epidural hematoma is very miniature arteries are mainly involved. Okay. Next. Okay, so this is important clinical aspect. Epidural hemorrhage. The anterior division of miniature artery is related to the area and it is the commonest source of extradural hemorrhage. Okay. Okay, that's all for today. So you read the important sinuses, prepare cavernous sinus as a short note. And dural pores also is short. Thank you.
Actually, it is a important to consider that and make it very only allow to and your schedule and different now. The second time I will go and obviously if you talk here and we all connect over there and start talking, how will you feel identified? And that is exactly that occurs to you. So, in the start, is also, while I think not that topic, and he has done 22. Last year, unfortunately, I tested all the work in the academic and we don't want to finish in class, we will in class, and we will get ready. So, it's not that we are realizing that we move very into time, so we much more important. In the last topic was give your existence India and here is Katarak technically and here are not but this is the question paper your last batch nothing can happen at this type of physical question that said and I think for activity here question 9 4 tasks. So we will learn from that. See, we are having a relationship in normal relationship with the medical secretary and the public entity. You want to say your head to your own. So I want that the whole relationship mark never make way parliamentary specialized. At any cost, you have to maintain your relationship very well to the rest of your life. So this is a dangerous profession and your life is to protect at any point of time. So in yesterday's class and last two class there are 2 points must be correct. That while doing the indications were being got, there are 2 parents gland. This is a good for part. Parents gland. What are the other important? It is not the parents gland. And secondly, that is called proper gland. Not strong. You get my mind. Why is it on the parents' gland and why is it on the daughter's gland? That is a good for you. And also I have neither application because I am lazy. This is the key word in the application. In medical science, we put on a lot of different terminology, and all these terminology are having specific connotations. Those who have not, but say yes, medical dictionary, and the hero or the entire of the I personally brought up the dictionary to get back the dictionary so have a medical dictionary. And both terminology, at least medical dictionary will help you a lot during your immediate secretary. Waiting for the not something to how to read a medical dictionary. That is one shot, very important. It is not a fast other. So, purchase a dictionary that will be useful. So, that is what I wanted to say. Today's topic today I am discussing on genetic code and mutation. Basically, I wanted to talk about mutation, but not genetic code. don't understand it properly, the nutrition. Now all of you have some amount of idea about the report and nutrition. There is no doubt about it, but you all have learned. All you have learned is class together. I am telling you details, but this class is not over the hardware. Only thing is that now I just want to. So there will be four applications. First, I will cover there will be four. Just note down whatever has been today. That is the most important. Note down right what is it which has been see what is generated. It says system of rules even to store the living position with the head. That's it. Remember the living form is based on the atmosphere of 8 RNA, and this 8 RNA is coded as per here. So sympathetic is the specific mRNA. Complementary to sympathetic is of here. Only for the particular signal. Only is sympathetic. Comparative nucleotide. The motor can indicate one amino acid specifically. It can indicate start signal and also various substances. So the orthogonal modes for amino acids are start signal and a stop signal. And the paramount importance is unit. The standard delivery code, which you see is called external. It's not literally DNA. I tell you what is DNA, what is RNA. See, this is an RNA code that will also give you a UCDAG. And this is an RNA, and since the DNA is not present, he is present in the same sequence is maintained, TCAG, the amino acid and the amino acid are set in both of them. Only instead of you will carry T. So this mRNA is produced from DNA by transcription. Transcription produces mRNA, RNA and carotid. mRNA is basically used for coding. Mutation can occur also while transcribing from DNA or RNA. That can also. Here you see is coding for viral RNA. Here EUNCC is coding for same amino acid. This is important to create a protein and RNA. Yesterday I summarized everything. I spent a lot of time and wanted to sequentially arrange it. See, I will show you the next slide that we are really going back in the hardest detail. So that is called intimacy of the whole. I will tell you the 6 features of codon in a short while. So remember, the number of codon which is available is coding for say nominated like 4 codons are there for value coded valuable license. Similarly, 6 codons are there for second license and internal artery. Now you look at this table very carefully. See, I have arranged delivered this to show you. See, these things look at the path Nucleotide. After we say the EU, the cell is becoming a cell. E gate is and if you go here also, C, this is artery, there is one from here. Here you can say that is CU. So this is a small motor which are actually determinants and the number of neurons they are present in the amino acids are like this. This is because our body has become controlled from evolution. And there is an evolutionary mechanism not to allow to make a non-control. Immediately, non-control of body, among because of the presence of so many mechanisms compensate for that mutation, the nature has evolved. You see, there is only one structure, that is A, but the thing is not these you must remember. So, 6 products are there for 4 products, 5 products are there for having for high amino acid and 6 products are for 3 amino acid. So why this is important? Just a little part is and there is evolutionary or law mechanism to make a control for the country despite identification. But as a work of protein, some parts are exposed outside, some parts inside. Here, hydroponic interaction can be performed. The exposed part of the body, exposed part of the body. Usually, mutation copper in the exposed part is managed to provide some amount of effect of that particular. But it happens said, it may not impact unless it is in a very particular condition. And so, for example, of mutation AGA disease. And you will see that weight is involved in that mutation and we will not be able to carry oxygen, so consequently we will not be able to function properly. So why we see there are so many items inside this discovery classification there. So instead of very the same adaptation will be provided. So that structure will be maintained. Similarly, with already instead of responding to the different diseases there, it will be maintained. But if the recurring acid will be poorer subsequent numbers in one polar, then that is all. And that will be there. And so this is the criteria. So evolutionary conserved kinds of basically proper evolution. And there are multiple clones for the same amino acid and possible. I will tell you. See, if this clone changing the surface, there is no impact and describe this thing. In detail in the previous slide, the number of clones, number of one, clone, this clone, and this clone, that is you might not. So more than one clone, that is infinite. So these 6 features are very important. Faster, more, simplest for is simple. That is very important. Second is universal. It is produced for the same amino acid. And it is observed in the human. All the generate and produce more than 1 in usually one amino anterior. One codon stands for one amino acid, but one amino acid can be encoded by so that is I said before, do not bother. Otherwise, you will not be able to gain property in control. And last, uncomplicated things that are not able to do until they come from the thing doctor. They are not able to and I for non-complicated. So these 6 parts, you get universal, unreversed, non-complicated, non-volatile, and here in the 6 parts you must know. When the third question is asked. So this is for can be one of the will. These points to root out. The rows of DNA yesterday mitochondria is also activate DNA which is generated from the mother. So mitochondria is also having a full that is so you know all the so they produce glucose. And mitochondrial produces the slightly different than the central glucose. And the mitochondrial data produces except this 4. You see, UTA is a normal partition for the glucose, but A is another glucose for mitochondrial. Similarly, A is coding for hydrogen inside the cell. What is coding for glucose? To begin this question is to present everyone this word for remember. I thought to very well tell you like this way. So with this said, describe in it's a huge topic and we will cover it with the second part and you must remember these points very well. You cannot see it come here and you take it. But you will note down all these points. Yesterday, told that it is not moving. There is occasional failure. In total, there is already that 3,000 steps to produce apparently. So that repetition is leveled by the different mechanisms. 2 of the different mechanisms have been covered by the education last year. That is the mass here, basically constitutes the cancer, and here are the mechanisms that is posted last year. So these nuclei, executed in the last year, and also I think scientists that are non-specific so normally this DNA because of the capacity normally it doesn't occur. So we have to far say the signature checking they have done. Explain every checking they are done that every projects but this normal security checking. So that happens in output generation. No system is 100% perfect. There are might be 0.00001 or something like that percentage of error. And that is mistake. But most of the damages, as I discussed yesterday, are caused by heat, UV light, and radiation, X-ray, UV of polar code, and we have to minimize ourselves from this type of radiation. Similarly, clinical effects are also there, and we are exposed to the outside environment where data demonstrates suppose most of the people are saying, fond of taking what food. And if you take what food it is there, so mucosa cells will be damaged and will constantly exposed to heat. So if somebody is living every day with heat, there is a high chance that they will develop full cancer. Because the cells will respond to the different way that light is living in and that is called moving. And their cells will not become normal. So you, to this day, are actually more motivated amount. So back from the level is again not known but only one we have note down. Single solar cell, two solar cell, same break and cross membrane. Single breast operation was thrown aside yesterday and immediately deep unit. That might be deep inhalation, just right out, otherwise you will not be able to remember. It is very difficult to remember. Actually, this thing that is not possible. You have to write out all this. But you have to write. No, 2 ways of correction. Again, this is the only thing that you will write and do. I will quickly try one. And one is diamond is gone. The cells cannot be separated. Same way. Like from the internet, the RNA radiation. Area of the disintegration. We call the emission of summarized. That is for stimulate and cross-stimulate. Can come out with the same trend all across the internet. So cross-stimulate is there. These 2 points are there. What we are discussing is very much data nutrition and quantity. What is data nutrition? Data nutrition are presented as germ cells, and these are really delicate or delicate. So, owners are to protect from radiation at any cost, particularly those who are cancer related or the parameters stage of one side, because that do not expose radiation. There will be chance of radiation, and that's the consequence of things. Mobiles are being used against from soil. Also, it is said that the parts of the very close to the plant, if we direct from the plant, do not contain. It's my more concentration, it might cause some amount of stress in and out of stress, in most of the time, and that's the realized after your radiation. So, there is a person in the radiation for the X-ray. So, no pregnant woman or anybody human being pregnant should be in the vicinity of X-ray or permanent. So, what is a girl pregnant woman avoided to expose to X-ray and CT scan are basically X-ray. We are able to ultrasound, we are test, but we use the artificial to ultrasound. One definition of art, when concept of thyroid is formed, it can happen in utero, it can happen after birth. One definition is something which occurs in our life, exposed to X-ray radiation of any part of the body, either dermatology, either different activities, but that will not be adequate. If the exposure is too high, that means the will not be that much. We are going to not be that much. And that area will be and all the factors are done. In the DNA paternity test, normally, whether it is biologically father or mother, is determined by the parents. And that is physical nature, DNA is there. If a child suffers from a genetic disease, but neither the mother nor father What is the possibility? The possibility is it's a great division in the prediction, number one. Number two, the gonads are exposed negation, that's why gonads are having abnormal behavior in the somatic cell area. Normal behavior is not to the blood. That's it. Now, we did not come from the structure from number one. Now, there are two more steps of DNA. DNA of not related, but it is not see, if you have that knowledge, then you will be able to explain something because it is tested. It is very important test. Here it is tested. In our hospital, what happened on day 1924, doctor normal doctor. Now, one report was that was guided to the doctor. Both was supposed to be the deep crowd outside the plasma to ambulation and blood. See for the data spectrally and half day such as the also is my person was there. There are some indications that are once I said this will be in the test and all these I can expect what is the difference the changing control does mean that the report was not in the distributed case, the other information that it will be fixed, it is not good. I want this thing because I will not get any chance in the future. Coming the way of it, that is regulation of nutrition, any change in the nutrient system, the food of any change in the nutrient system that is very important. Nutrition. So that the application of measure and control of the exquisite hypervitamin and that is due to nutrition, but by and large, of nutrition and there is really nothing bad as substitution, deletion of nutrition for nutrition. See, in a coding sequence, what happens? See, if the A is converted to the B is converted to volume. This volume for volume to A, that is unique to unit, that is constant. What unique to unit? Unique to unit or unique to unit is called transition. And if it is between unique and unit and vice versa, like A to P or P to A, that is called transversal. So the transition means that the change is unique or unit. Transversal is so that's not the DNA sequence. You see the key types of point is very important. It is a point nutrition only at one point. Only at one point. Out of these three codons, only at one point this change is occurring. That is why it is important point nutrition. So that point nutrition can give transition, it can be transversal. it can result in no effect. You will save a message to put it by the number it's put on. It can be silent, but it change has occurred. But there is no difference in the functional aspect of protein. Although the protein is not the same protein, identical similar, there are two subdivisions terms, identical is exactly the same. Similar means some are similar but is not identical. So you can lead to nonsense. That means the first protein is actually here I am telling you. You can see this shape. A is the starting one. So obviously we start from here. And the red tube is because the gate somewhere by the A, that is the pronoun. So if there is any change in the cause, it will result in the same amino acid and no impact. That will, and if there is a change in the same group, will bring back, but it is a change of different thing. There is very little market to analyze. This is D is so that's the problem. Now here we have instead in the action. So there is a stop. And there is here I'm going to say like the impact of the write-down can be silent, it can be distant, it can be non-silent, it can be advanced, it is a little more silent position out of the low effect because of the so there will be so what is degeneration? Excess. Change in the path position for complete. So that change in the path position is mutation. This self mutation. This taken incorporated. And it can be of three that right now, it can be some sort of mutation, it can be acceptable, it can be partially acceptable, it can be not acceptable to all. And why acceptable? Because it is different between the organization and I spoke to the beginning, and it emphasized on the mind, similar functional groups are protected, partially acceptable groups combined functions. And so you that unacceptable. It will not be able to perform the normal function. That is not acceptable. So now you see the three types of research mutation, one is acceptable, one is not acceptable, and another is not. See, at least why I want I read that the key number more than the other things that are there are hundreds of conditions of improvement are there, but all these are produced changes. So many are acceptable. One is to change, acceptable position, life will be increased by happiness. So life will be increased by happiness. So there will be no change, but as I told you that particular jugular will not be identical. So there will be a property, there will be a property, so there are that is how it is. Partially acceptable, will not be beta change of jugular A, what is jugular S. And one of the development and both of the structure is can occur in the is can occur in the non-acceptable. Unacceptable is the alpha change. One acceptable 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 is the alpha chan that you take the water, immediately the film of the dish, after you get to the state, and the peroxide. These can carry oxygen, but because the close proximity for infinity, which is also having immediately that's anomaly, but that is the time is and infinity capable of getting error and we will not knock out the privacy is there, so we will not invent the error state anymore. The permanent state of steady state and not be able to carry oxygen, so that will cause great fluid formation. So that is unacceptable. So this is the problem of fluid. This is the alpha cellular. You can handle the detection, you can handle the non-detection. But alpha cell, basically the proximal disease, close to the proliferating, either in the gate position or in the eastern position, the detection. These errors form of other and then this one. So this symptom is due to sickle cell anemia, and the normal RBC state is required as part of the sickling. I will tell you that the shape of the RBC will not be required in the sickle subject, and the once it is sickle subject, that means that you will not be able to pass through the normal way, normal pathway. You will not pass it. Because of the disease, this is what sickling and we are going to spend on day-to-day head, and if the amount is not constant, the amount of cells is high. These points you write down whatever is visible. At the sixth position of the was given at home, the first class of the same class as the names. That is polar. In replaced by thyroid, falling simply hemoglobin, that is hemoglobin S, with sickling, that is separate artery, and that is the patient of sympathetic. So there are three harmful aspects of this sickling hemoglobin that we cannot carry oxygen in way normal hemoglobin gas. Second, we cannot pass through the that normal body. So there is a small blockage. And it causes acute syndrome, acute crisis to the bone. If there is blockage, the bone, capillaries, some motion. If there is blockage in the cerebral artery, it causes stroke. If there is a blockage in the venous, physical cells are moved around, and it is inoxygenated. So in the venous, outflow is not absorbed, and there is venous obstruction. There is outflow obstruction. There is blockage. So the infant for crisis and prostate crisis is the resource. Vessel is blocked. Sickle cell crisis. Speed, large amount of large not able to come out of the speed is large. The soft crisis will be on first stroke I have told. And significant syndrome called various cells of the alveoli. So what is this? But it's not technically and that occurs to the side. It actually stroke. Not the stroke of the opposite side. But why it has stroke is effect. So that heart is being to rate of oxygen, what factor, and that will be the activity. That's one video. Normally, artificial inspection. signal only on the equator. Equator water blood level, that will not allow the blood flow to occur. That happens. This is common disease. British also common disease caused by deletion of the genes affecting the kidney. Normally, there are two alpha to infections and alpha is related to the life. Alpha is related to the life that you are similar to and it is all in the production of non-alpha cells in the head, and that's why detected after 6 months of age and is formed. So the life more percentage. If the ATPA is more than 2.5%, one must suspect that it is a case of thalassemia failure. Electrophoresis is one of the clinical of thalassemia failure. And one thing I remember and I read a lot, why this electrophoresis quite common in this area. See, one submental is area of full of mosquitoes, and they look for malaria. And malaria parasites spread within the RBC. And this is classical example of female thermonuclear cell. No organism wants to die. So, human being evolved in the organism so that the life from the organism is protected. Instead of 100 to 120 days, the organism life is protected. Malaria parasite, which is within the organism, survives in the organism, will no longer be able to survive as that malaria parasite is phagocytal parasite. And that is the mechanism why immunoglobulins are common in the mosquito area. Now, since that is in the robot, for 700 years of here, if we want to go back to the particular case, we have to make this area at least mosquito for 300-400 bacteria. That is how we have that. This is one of the reasons immunoclass forming kind of reaction that it is due to gene, so different minerals that involved and a combination of immunoclasses by either person in the RBC life, critical product of RBC life, depending on the situation of what the person is alive. So, everything accommodating like module, basically, it will be A, C, E, and E, but one disease is called artery. If the alpha is accepted for alpha function, the beta function is less, that is what is the artery. These two forms artery that is very common and 5 kilograms, nearly 1,000 pages, that is also very difficult to digest. So the excess of other type of things, normally students are protected from the suggestion, but this is one of the things that is excess amount that we protect with the red cell and the red blood cell, that is why red blood cell divides and it is not known. And then there is why we can use it to get product in the physical level. So nonsense nutrition that we are aware of after the stock column, the transfer them to stock. What the start from effect here. So we have the whole thing. I call it non-program. So what example of this thing is example non-information is just one example of the rule. That is CMPRC. Transport from life, very important, only thing you will not have most common human medicine is 500 days is for product, and that will become from what? That will be a long one, and then the main problem of CPS is that 500 days certain about that thing, but you do not have or your law. So it is possible that so one C is in here. So again, so that will be said all the lessons of reading failed. Same situation, it can be insertion or deletion of one or two or three units. So deletion of single unit, there is no complication. That's particular analysis is absence of no complication in the reading pronoun. See here it is converted gives it. But the problem is that the protein is turned to mutations with the body. The sequence you want to say, the problem is here, there is no problem. So protein synthesis is turned to the site of insertion or deletion, that is, we call it carotid. Insertion of single nucleotide. Single nucleotide occurred here, and again the carotid. Software is here, software is here, software is here, software is here. Again, but if an insertion of sympathetic, corresponding is the reason of three nucleotides, the three nucleotides upset, but there is no problem in the software. But if there is an insertion, obviously that one ability to incorporate. You sum that about whether the slide insertion of one or non-modular things. Non-modular things, that is 2, 3, 4, 5, 6, 7, 8, 9, 10. Right? The insertion of deletion of that one. Included for either deletion or insertion of that one. But the deletion of one program followed by insertion of another program. We know our different. What problem is that the inner portion of the protein. That is what we want to do for one. Into that one from if 3 crores are deleted, one applied, one side, and 3 crores are inserted. In a substitute, so structure will remain same, but the inner portion of the protein will not be functional, just like the polymer. Any number of any insect can occur, and that is the basis of many things, very good data. So that control of the product, and given for by expertise, guide and in fact, what step you can program between there are some point on the department. Thank you very much. So just read it. If you do not understand anything, you will get everything in the class. Thank you all. But read in the center. I think in that discuss it, I will expect some questions from you. And I will happily hear my answer. Because that one thing that I want to answer, it's not a bonus factor. I will speak and you will speak I want to learn something from you. So please ask me some questions. I will not go to so that is what all subsequent discussions in my head ask me in the okay?
Okay, so yesterday yesterday we discussed the boundaries of anterior triangle and its components. Okay, 3.5 triangle. We have discussed the 4 triangles: submental, muscular, digastric, and carotid triangle. Okay, and you have also seen the boundaries in the category. So, some contents of the carotid triangle we will discuss today. Okay. So first is common carotid artery. These are contents of the carotid sheath. Common carotid artery is the main artery of head, neck, and brain. Main artery of the head, neck, and brain. And beginning, how it begins? The right common carotid artery arises from the brachiocephalic trunk behind the sternoclavicular joint, and the left common carotid artery, they arise from the arch of aorta. Okay. What is the course? Each common carotid artery runs upward and laterally from the sternoclavicular joint to the upper quarter of the thyroid cartilage. How it terminates? Each of the common carotid artery divides into internal and external carotid arteries at the level of upper quarter of lamina of the thyroid cartilage. This is very important. Where is the termination? This level. Okay, upper quarter of the lamina of the thyroid cartilage, and it corresponds to the disc between C3 and C4 vertebra. Okay. Now, what are the branches? The common carotid artery does not give any other branch in the neck. All the branches are coming out from the external carotid. Now, what is the clinical integration? Carotid tubercle. It is a tubercle on the transverse process of C6 vertebra, and common carotid artery can be compressed against this tubercle. Okay, that's why the name is carotid tubercle. And it lies about 4 cm above the sternoclavicular joint. Next is carotid sinus. Carotid sinus is fusiform dilatation at the bifurcation of common carotid artery. It has baroreceptors. Okay. Innervation key it receives fibers from glossopharyngeal, vagus, and sympathetic nerves. What are the functions? The baroreceptor of carotid sinus regulates the blood pressure, and stimulation of carotid sinus as increased blood pressure produces a reflex fall of BP and flowing of the heart. Okay. Now, carotid body, it is a small oval neurovascular structure situated behind the bifurcation of common carotid artery. Structures, it is a reddish brown structure and it has chemoreceptors. How it is innervated? It is supplied by glossopharyngeal, vagus, and sympathetic nerves. What are the functions? Chemoreceptors get stimulated by excessive carbon dioxide or reduce oxygen in the blood and produce rise in BP, heart rate, respiratory rate, and depth of respiration. Clinical integration here is the carotid sinus syndrome. It occurs in patients with hypersensitive carotid sinus, and these patients undergo sudden attacks of syncope or fainting and slowing of the heartbeat or rotation of the head. Now, potato tumor of the neck. It is produced by enlargement of the carotid body, and this tumor moves transversely. Okay. Generally, tumors of the neck they move vertically, but this potato tumor they move transversely. Okay. Now, internal carotid artery. So, common carotid divides to form internal and external carotid. Okay. Now, we will discuss internal and external carotid, and then the branches of external carotid artery. So, internal carotid artery, it runs as upward continuation of the common carotid artery, posterolateral to the external carotid artery. Ascends upward in the carotid sheath up to the base of the skull, and it extends into the skull through the carotid canal. Okay. Carotid canal lies within the petrous part of temporal bone. Now, the internal carotid artery does not give any branch in the neck, and structures passing between the internal and external carotid arteries in the upper part of neck are the part of the carotid gland. These are sometimes asked in your Viva. What are the structures passing between internal and external carotid? Okay. So, part of the carotid gland, stymate process of temporal bone, styloglossus muscle, stylopharyngeus muscle, glossopharyngeal nerve, and pharyngeal branch of vagus. These are passing between the internal and external carotid. Now we go to the external carotid artery. It is the main artery supplying external carotid is very frequently asked in your Viva and OSCE. Okay, its branches are asked. What are the branches of external carotid? And their course you have to see in this anterior triangle. So external carotid artery is main artery supplying the structures of the neck and face. How it begins? It begins as a terminal branch of common carotid artery at the level of upper border of thyroid cartilage opposite the intervertebral disc between C3 and C4 vertebra. Okay. What is the course? It runs upward and slightly backward and laterally. Termination, it terminates within the carotid glands by dividing into the maxillary and superficial temporal arteries at the level of neck of the mandible. What is the relation? External carotid artery runs in the carotid and digastric triangles and then in the substance of the carotid gland. In the carotid triangle, the relations of the external carotid are superficial and deep relations are important. Superficial, the artery, this is here, this is common carotid, this is dividing at this level, here dilatation is known as carotid sinus, and here lies the carotid body. Okay, so dividing into two branches, internal carotid, external carotid. All the branches in the neck is given from this external carotid. Okay, first these five branches are coming in the neck. Ascending pharyngeal, superior thyroid, lingual, facial, occipital. Okay, posterior auricular is in the posterior triangle or behind the ear it is lying, and these two branches are given within the substance of the carotid gland. Okay, these two are terminal branches, superficial, temporal, and maxillary. So in the carotid triangle, superficial relation is sternocleidomastoid, cervical branch of facial and hypoglossal nerve, and three veins: facial, lingual, superior thyroid veins. Deep relation, wall of the pharynx, superior laryngeal nerve, ascending pharyngeal branch of external carotid artery, and the internal carotid artery. Now, in the digastric triangle, external carotid artery enters the digastric triangle by passing deep to the posterior belly of digastric and stylohyoid muscles. Then the external carotid artery enters the carotid glands, and relation with the carotid gland, superficial relation with retromandibular vein, facial nerve and its branches. So within the carotid gland, superficial most lies this facial nerve and its branches. Deep to it lies this retromandibular vein, and deepest is this external carotid artery. Okay, so three structures: nerve, vein, and artery lying from external to internal within the substance of carotid gland. Now, deep relations is deep part of carotid gland. Other deep relations are internal carotid artery, styloid process, styloglossus, stylopharyngeus, glossopharyngeal nerve, and pharyngeal branch of vagus. Okay. Now these branches are very important. Okay, very frequently asked in your Viva, also important for your OSCE questions. So external carotid artery gives 8 branches. These are medial branches. Medial branches are 2 posterior branch and 2 terminal branch. Okay, medial branches are 4. So ascending pharyngeal artery, 3. This is medial branch. 3 anterior branch. Superior thyroid, lingual, facial, 3 anterior branch. Posterior branch is occipital artery, posterior auricular artery, and 2 terminal branch, superficial temporal and maxillary. Okay, so All these are branches of the external carotids. Branches are very important. Next. So it begins as terminal branch of common carotid artery at the level of upper border of thyroid cartilage. This level is very important. Terminates by dividing into maxillary and superficial temporal arteries within the parotid gland at the level of neck of the mandible. And these are the branches: ascending pharyngeal, superior thyroid, lingual, facial, occipital, posterior auricular, superficial temporal, and maxillary. Okay. Now we will discuss the individual branches, their course and the supply. Okay. So external carotid artery gives 5 branches in the anterior triangle. So we will discuss mainly these 5 branches in details now in the anterior triangle. Ascending pharyngeal, superior thyroid, lingual, facial, and occipital. So first is ascending pharyngeal. First and smallest branch of external carotid arises from the medial side of external carotid artery, ascends vertically upward to the base of the skull and along the lateral wall of the pharynx. Branches, it gives these branches, pharyngeal branches to the pharynx, tonsil, pharyngeal ends of auditory tube and soft palate. Inferior tympanic branch to the medial wall of the tympanic cavity, and these branches enter the middle ear through the canaliculus for the tympanic branches of glossopharyngeal nerve. And meningeal branches that enter the cranial cavity through the foramen lacerum, jugular foramen, and hypoglossal cavity. Okay. Next, we go to superior thyroid artery. From the name, you can know it is supplying the thyroid gland. Okay. So it is the first anterior branch of external carotid. Previous one was medial branch, ascending pharyngeal. First anterior branch of external carotid that arises just below the tip of the greater cornu of the hyoid bone. What is the course? It runs downward and forward along with the external laryngeal nerve, and it passes deep to the infrahyoid muscles and superficial to the inferior constrictor of the pharynx to reach the upper wall of the lateral lobe of the thyroid glands. What are the branches? Superior thyroid artery gives these following branches. Infrahyoid branch runs along the lower border of hyoid bone. Superior laryngeal artery that pierces the thyroid membrane along with the internal laryngeal nerve supplies the larynx. Picothyroid branch anastomosis with the same branch of opposite side. Sternocleidomastoid branch to the sternocleidomastoid muscle. Then terminal branches. Superior thyroid artery divides into anterior and posterior branches, and that supply the thyroid glands. Okay. The superior thyroid artery and external laryngeal nerve diverge from each other as the artery approaches the thyroid glands. Hence, in thyroid gland surgeries, superior thyroid artery is ligated near the gland to avoid injury to the nerve. Okay, this is important. Explain my question. During thyroid gland we have discussed. Okay. Next is lingual artery. It is also anterior branch of external carotid artery that arises opposite to the greater cornu of the hyoid bone. What is the course? It is a tortuous course divided into 3 parts by hyoglossus muscle. First part lies in the carotid triangle. It has loop with upward convexity, permits the movement of hyoid bone and tongue, and this loop is crossed superficially by the hypoglossal nerve. Now second part, it lies deep to the hyoglossus. So hyoglossus muscle is dividing this artery into 3 parts. Okay, this lingual artery. So second part lies deep to the hyoglossus, runs along the upper border of the hyoid bone between the hyoglossus and mediconstrictor along with hypoglossal nerve. Third part is known as arteria profunda linguae or deep lingual artery. It runs upward along the anterior border of the hyoglossus muscle. Further, it runs horizontally forward on the ventral surface of the tongue, just deep to the mucous membranes on each side of the frenulum linguae. And the horizontal part is accompanied by the lingual nerve. What are the branches? It gives this suprahyoid artery, dorsal linguae, sublingual artery. Suprahyoid artery passes along the upper border of the hyoid bone. Dorsal lingual artery 3 to 4 in number arises from second part of the artery and they supply the dorsal surface of tongue, palatine tonsil and soft palate. Okay. Then sublingual artery arises from third part to supply the sublingual glands and the floor of the mouth. Clinical aspect here during surgeries of the tongue, that is surgical removal of the tongue, the lingual artery is ligated before it gives any branch to the tongue or tonsil. Okay? Because there will be bleeding if you don't ligate it. And this tongue surgery is done generally in tongue carcinoma. Okay? Next is facial artery. You have read during the face. So facial artery is the anterior branch of external carotid, arises in the carotid triangle just above the lip of the greater cornu of thyroid. Two parts, cervical and facial. Cervical part of facial artery passes upward and forward deep to the posterior belly of the digastric and stylohyoid muscles. And it passes upward and forward deep to the posterior belly of digastric and stylohyoid muscle, loops around the submandibular glands, takes turn around the lower border of mandible to reach the face. Okay. Facial part of facial artery. It enters the face at the anterior inferior angle of the masseter muscle. Okay. And it has a tortuous force in the face along the angle of the mouth, then along the side of the nose up to the medial angle of the eye. Okay, so that will be the force of facial part of facial artery. What are the branches from the cervical part? Ascending palatine artery arises near the origin of facial artery and ascends upward between styloglossus and stylopharyngeus. It winds around the upper border of superior constrictor, supplies tonsils, soft palate, pharynx and auditory tube. Then tonsillar artery, it is the chief supply of the tonsil, pierces the superior constrictor to reach the tonsil. And glandular branches for the submandibular gland, submental artery accompanies the mylohyoid nerve and it runs along the lower border of the mandible. Now branches from facial artery in the face, three branches mainly, inferior labial, superior labial, supplying upper lip, lower lip muscles and lateral nasal artery. So these are the branches from the facial artery. Next we go to occipital artery. It is the posterior branch of external carotid, arises opposite the origin of the facial artery, passes upward backward along the posterior belly of digastric, passes deep to the sternocleidomastoid and splenius capitis. It runs in a groove on the medial side of the mastoid process. There is a groove on the medial side of mastoid process for this artery. We have seen in the bones. And it pierces the trapezius along with the greater occipital nerve to enter the scalp. And these are the branches from occipital artery. Sternomastoid branch, upper sternomastoid branch accompanies the spinal accessory nerve. Lower sternomastoid branch loops around the hypoglossal nerve. Mastoid branch enters the mastoid foramen to supply the mastoid air cells and meninges. Meningeal branches enter the cranial cavity through the jugular foramen and condylar canals. Then muscular branches, descending branch, it divides into superficial branch which anastomoses with the superficial branch of transverse cervical artery. Next we go to posterior auricular artery. Branch of external carotid arise from posterior aspect opposite to origin of facial artery, passes backward upward along the upper border of posterior belly of digastric, passes between the parotid gland and styloid process. In between the mastoid process and the auricle, it divides into terminal branches, auricular and occipital. So branches are and their supply. Stylomastoid branch enters the stylomastoid foramen, supplies the middle ear, mastoidectrum, its ear sacs and facial nerve. Auricular branch supplies the auricle, occipital branch supplies the scalp. Next, two terminal branches, superficial temporal and maxillary. Okay. Superficial temporal is smaller terminal branch of external carotid, arrives within the carotid gland at the level of neck of the mandible. Runs upward across the root of zygomatic arch, anterior and posterior branches to supply the scalp and temple. What are the branches? This artery is important. This you may have seen in face dissection. Okay, transverse facial artery. It comes out from the anterior border of the carotid gland. Arises from superficial temporal artery within the carotid gland, passes forward along with the zygomatic branch of facial nerve, supplies the carotid gland, temporomandibular joint and the face. Then anterior auricular branch to the auricle and external acoustic meatus. Zygomatico-orbital branch to the face. Middle temporal artery pierces the temporal fossa to supply the temporalis muscle. Then anterior and posterior division supply the temple, scalp and auricle. Okay. Now maxillary artery, last branch maxillary, second terminal branch. Okay. Superficial temporal and maxillary. Larger terminal branch of external carotid that arises within the carotid gland at the level of neck of the mandible, and it passes forward in the infratemporal fossa. Submental lymph nodes. Okay. Now these are the clinical aspects. Okay. Submental lymph nodes get enlarged in the infection of mouth, tip of the tongue, and inside the teeth. And these nodes can be palpated below the chin. Digastric triangle has the swelling from these following structures: enlarged submandibular lymph nodes in the infection of tongue, floor of the mouth, frontal, ethmoid and maxillary ear sinuses. Okay, so these are the clinical aspects. Which structures can form swelling in each of the triangle. You have to know the contents of the triangle. So if infection involves those structures, there will be swelling. Okay. Okay, so again we will see the boundary and then we will end. Okay, see now today also we will see the boundary and the contents, mainly the contents of the carotid triangle. Okay, so this is boundary of the whole of the anterior triangle. What will be the incision line? First, you know, incision line extending from symphysis menti along the midline of the neck up to the suprasternal notch. Okay. Then another incision line extending from symphysis menti along the base of the mandible up to the angle of the mandible. Then extend the incision posteriorly up to the mastoid process. Okay. After that, we reflect the skin and superficial fossa laterally and downward. Okay. Within the superficial fossa, we get fat, the cutaneous nerves, and the platysma muscle. This is seal of muscle. So fibers of platysma we see within the superficial fossa. After that, we have to remove this. We will see the triangles and their boundary. After that, you will get the deep fossa. Deep fossa here is the investing layer of deep cervical fossa, which is forming the roof of all the triangles. Okay. After removing this deep fossa, we will see the boundaries. Here we will again discussing the boundary. First, the submental triangle. This is forming half of the triangle. Apex is directed above, formed by symphysis menti. Base is formed by body of the thyroid. On two sides, two anterior belly of digastric. Okay. Floor is formed by the mylohyoid muscle. So this is submental triangle. Next triangle we go digastric triangle. So what will be the content of this submental triangle? We will see the submental lymph nodes. Lymph nodes has been removed, and anterior jugular vein or submental veins are joining to form the anterior jugular veins. These are the content of submental triangle. After that, we will go to the digastric triangle. Digastric triangle, base is above, apex is below. bounded base is formed by base of the mandible, the line extending from angle of the mandible to the mastoid process. Anterior boundary, anterior inferiorly bounded by anterior belly of digastric, posterior inferiorly by posterior belly of digastric and stylohyoid. Okay. Apex is formed by intermediate tendon of the digastric. Floor is formed by the mylohyoid, hyoglossus, okay, and superior middle constrictor muscles of the pharynx. Now we go to the muscular triangle. Muscular triangle is bounded in the medially by the anterior midline of the neck, posterior superiorly by superior belly of omohyoid, posterior inferiorly by the anterior border of the sternocleidomastoid. Okay, and here infrahyoid group of muscles we will see, superficial group 2 muscles, medially sternohyoid, laterally this omohyoid, superior belly of omohyoid, and in the deeper plane 2 muscles, sternothyroid and thyroid. Okay, understood. Next we go to carotid triangle. Carotid triangle bounded posteriorly by the anterior border of the sternocleidomastoid. Okay, anterior superiorly by the posterior belly of digastric and stylohyoid, anterior inferiorly by the superior belly of omohyoid. Okay, its contents will be carotid sheath and its contents. Along the anterior layer of the carotid sheath, we will see the ansa cervicalis. Okay, and within the carotid sheath, we have to see the common carotid artery, its division into internal and external carotid artery, internal jugular vein, and in between the artery and vein at the deeper plane will lie the vagus nerve. Okay, and posterior to the carotid sheath, you will see the sympathetic chain. So all these are content of the carotid sheath, and also in this triangle you will see the branches of the external carotid artery. No branch from common carotid and the internal carotid artery, and at the site of bifurcation you will see the carotid sinus. So in this dissected body you can see 3 branches: superior thyroid, lingual, and facial. Okay. So all these you have to see, and here in the digastric triangle we have removed the superficial part of the carotid gland, and you will see the floor muscle that is mylohyoid, and you will see the hypoglossal nerve. Some part of the spinal axis you will see in this posterior part. Okay, and in the upper part you will see the origin of facial artery and the lingual artery. In the some part of the digastric triangle. Okay, so all these you have to see. Okay, understood? Okay, now you go to the cadaver.